Good afternoon, everyone. My name is Paul Mitchell, and I'm delighted to be here sharing another of these short interviews to coincide with the launch of the Hip Fracture Registry Toolbox. Today, we'd like to welcome Dr. Hannah Seymour, who is a consultant working in orthogeriatrics at Fiona Stanley Hospital in Perth in Australia. Hannah is also President-elect of the Fragility Fracture Network and co-chair of the Asia Pacific Fragility Fracture Alliance Hip Fracture Registry Working Group. Hi, Hannah.
Good afternoon.
Good to see you. So I understand that Hip Fracture Registry Audit has been going on for some time in Western Australia, and it was really piloted quite a while ago prior to the establishment of the Australian and New Zealand Hip Fracture Registry. So could you share your experience and your colleagues' experience of starting that pilot, that early work, and then go on to talk about early participation in the Hip Fracture Registry at a national level and that journey to nationwide participation?
Thanks, Paul. And look, just before we start, it's worth saying that we're really excited about the launch of the Hip Fracture Registry Toolbox, and we do hope people will use it to help get started. I think what I'm going to describe is how you should just start somewhere and you should use opportunities that come up. And it won't be perfect to begin with, but starting somewhere, collecting something, comparing to other people, and then gradually building from there sometimes is easier than starting with a national approach, which can sometimes be quite difficult. So we have had a geriatrician interested in hip fracture, orthogeriatrics and rehabilitation for a long time. So Peter Goldswain was his name, and he worked at a hospital called Shenton Park for some years. So way back when I was a trainee in 2002, Peter had been collecting hip fracture data for a very long time, way before the start of the National Hip Fracture Audit in the UK. The problem with that was he collected a lot of information and used it sometimes to generate research questions or to do some quality improvement, but no one else was collecting the data set. And so there wasn't really other units to compare to. So back in about 2010, I had a leadership role within our health department, but we got all of the orthogeriatricians together and we talked about starting to collect a standard data set. And as with many things, people wanted to collect quite a lot. And that was a bit of a barrier at the time to getting started because people couldn't see how you could have the time to collect a lot of information. So we waited a bit. And the UK Hip Fracture Registry database started publishing their reports. And that gave us the opportunity to have a designated data set that was much smaller. And it gave us something to start with, because if we collected that relatively small data set, then we could start comparing to the UK. And it was much more feasible to collect that relatively small data set than it was the original data, which was much, much bigger. So what we did was we then took an opportunity, and often in systems, there are small opportunities that come up and we should try and grab those. So there was an opportunity here to set up a quality improvement process with a small amount of funds to help us. And that allowed us to really agree that data set up a local system to collect it, and fund the initial nurses to collect that information. There were still barriers, it still wasn't perfect. So we started collecting that data in 2011, and it wasn't a panacea. It wasn't that every hospital started collecting data straight away. But what we did was we gradually got hospitals on board. And first of all, there was one, then there was two, then there was three, and then we expanded it beyond our tertiary hospitals. So we're a relatively small system in terms of the volumes of sites. So once you had 3 hospitals collecting information, it really became quite meaningful to compare our care and things that managers were interested in, like length of stay, between sites. And that then gave us the opportunity to continue that work because it became part of our core business, and there was an understanding that it really wasn't a big imposition to collect the amount of information that we wanted. So again, I think it's a real lesson in just start somewhere, start with something, even if it's a month or a week of collecting data at every site, just to see what it feels like, to see how much time it takes. Collecting less, not more, is a really good starting point. So even if you choose just to collect 5 things to begin with, the things in acute care that are easier to collect, just start somewhere, collect something. Ideally, try and get a few colleagues in different hospitals on board, and then build from there. So what we were able to do in Western Australia was collect that information locally. That gave us a bit of a head start when the National Registry started. We actually didn't contribute to the registry nationally till a bit later, because we decided that we were better off to begin with keeping our data while we set up the registry, started getting all of our ducks lined up. And then on the 1st of January, on a particular date, we chose to move our data set into the same one as the national data set, and move into that organisation and collect it in that very structured way with the ethics approval and all of the national things that we needed. Some of the benefits of doing things locally are it becomes a quality improvement process rather than submitting data to a national registry, which means that we did that under the auspices of quality improvement locally. That meant we didn't need ethics approval because we were keeping the data within Western Australia within our systems. We didn't need complex IT to help solve any problems because it was staying within our existing systems, and we weren't sharing that with anyone in any form that could be seen as a risk to WA health. So doing things locally first is actually quite a lot easier, but it got us all in the habit of collecting that information. We could all see that the information was of value to us in improving the quality of care we provided. It allowed us to start comparing locally, where we were very confident that the care was similar and that the systems in place were similar. So if you compare our data, the way that we care for patients and the systems of care between Fiona Stanley and say Prince of Wales, where Jackie Close works, the systems around us, so the access to rehab might be different. There's a lot of more complexity in comparing hospitals in different states, whereas because we work locally, we've all rotated around those hospitals. We were very confident that we were comparing apples with apples, and that we could use that information without questioning all of the way that we care, the fact that maybe our patients were sicker. We kind of knew all of that was not the case before we even started. And so again, I think it really helped us locally drive that and find the value in that. And now I don't think any of us would go back from collecting that information.
Yeah. So that brings a question to mind. Is you use the expression sort of business as usual from the practical perspective of key challenges in data collection, whether it was the early days or indeed later on. You know, what are your recollections there? What were the real bugbears and things you had to overcome to go from this not being business as usual to it being business as usual?
So it's who collects the data and who puts it in.
Right.
And I think that's the biggest problem when you're starting out, is to work out how you can collect the data reliably. So we did have a system already of some hip fracture nurses, but that won't be the case everywhere. And that's where I think, you know, to start out, accept compromise, that's okay. Accept that you're only going to collect 5 things, or accept that you're only going to do it for a week or a month to begin with, to see what it feels like. You don't have to have every problem solved, and you don't have to have the perfect solution. Anything you do is better than not doing anything. So collecting 5 things is better than collecting nothing, and accepting that it might not be perfect and you might miss people at weekends to begin with. That's okay. It will still give you really useful information about the quality of the care that you provide, how you perform generally, even if it isn't perfect to begin with. And start with something, and that then convinces people locally about the quality of that, the usefulness of that information, which allows us to make a decision which has more validity around investing in that, or making a decision that this is something that we want to really collect for the future, because it helps us so much. So we now have nurses who collect most of the data. Lisa, the nurse that I've worked with for a long time, is exceptionally efficient at that. And I think, again, that's the learning, is that you can get really quick at collecting this information if you do it a lot. For most hospitals with 100 or 200 hip fractures a year, you know, it's a couple of people a week. And breaking it down to that, how many people a week is this, makes it much more achievable. If you're looking after 100 people with a hip fracture, that's 2 a week. Well, if it's 10 minutes to collect the data, you're talking about 20 minutes a week. Whereas if you're looking after an awful lot of people with hip fractures, so we look after about 500 here, that becomes a bit more difficult to do in a few minutes here and there. But even doing it for a week or 2 weeks would give us therefore a lot of information, more information than other hospitals that collect that same information for a year, just because of the volume of patients that we have. So again, so what the quote that I like is, imperfect action is better than perfect inaction. And I think that's a really good quote when we're thinking about setting up registries or starting to collect information. And starting is always better than not starting.
Absolutely. So 3 final quick fire questions for you, really. Our colleague, Dr. Colin Gurry from the UK, says that continuous feedback is empowering to clinical teams. So thinking about when you came to the other end of the journey, and you've been participating fully in the National Registry for many years now, do you want to give us your thoughts and insights on that notion that the continuous feedback from the registry to clinical teams is empowering?
Yeah, absolutely. So look, I'm passionate about information and data driving quality improvement. We wait for the data to come out to see how we're performing compared to the rest of Australia, but we have always looked at the information regularly. We have a dashboard that allows us to do that, and so does the Hip Fracture Registry now. But again, I would really encourage people just to think a bit outside the box. Tableau, we use a dashboard, but now Power BI, for example, it's so easy in Excel spreadsheets to create. We started off with extracts that we could put into Excel with some macros on it that could give us some automatic reports and automatic comparisons. These are things you can teach yourself to do using a YouTube video. You don't have to have a perfect IT system, which is fancy, to do any of this. You can do most of this with Excel spreadsheets to begin with. And if you can find a friend who can help do those things with some knowledge, macros in a spreadsheet, giving you your time to surgery week by week is an ideal place to start. And you don't have to have fancy tools the way that IT has evolved in the last 10 years. So really, really encourage people to start somewhere and do something, and then gradually build. And registries are really valuable tools, but sometimes the complexity of that in countries with very tight privacy laws and complex ethics systems make them difficult, and you need that pilot information, the limited information, to take to those to larger national organizations. In some ways that might be easier in other places. And I think, we're very aware in FFN, for example, that, not every country is the same. There are lots of countries in Asia that don't have access to the resources that we have in Western Australia. And, that information is still really valuable. I go to conferences regularly and hear about the time to surgery in other countries. And that information is power, because if you're waiting 10 days in a hospital bed for the funding to put in a prosthesis, then that costs money too. And all of our organizations need that sort of information in order to change the way that we work to make things better for our patients. Absolutely. And at the end of the day, this is all about us caring across the world for frail older people with dignity and respect, and caring for them as we would want to be cared for, and reducing pain as quickly as we can, and getting people back to independence as quickly as we can. So that's what we're driven by. To do that, you need information and you need data in order to convince the system that we work in that we can do that better. And the way to do that better is individual to each organisation and each system. And if you don't have that information, it's really hard to change care.
Well, I think that's a perfect note to end on. Dr. Hannah Seymour, thank you so much for your insights. It's really going to be useful to colleagues around the world. And just to reiterate Hannah's point, you will see at the end of this little presentation a link through to the new Hip Fracture Registry Toolbox. We hope that's a distillation of the world's experience of colleagues like Hannah, so that those colleagues who want to begin to collect data and then go on to greater things and build registries, they can learn from the lessons of the past. So thanks.
Yeah, and Paul, thanks. Just to add to that, FFN, as you know, is working really hard to develop some tools and some opportunities for people in countries with less developed systems to really build on this information. And part of the toolbox idea is that we then get local experience in different countries, and we can continue to share that, so that it won't be someone from Australia in a very well-developed system giving these talks. It'll be someone from the Philippines or someone from China, where they have very different challenges. And we really want to encourage you to register for FFN and hear about those opportunities as they come up, so that we can continue to share the knowledge of the most across the world, so that people can in other countries can improve care quicker than we did.
Absolutely, absolutely. So thanks once again, Hannah. It's really helpful, and thanks for everyone who's tuned in.